Regarding the differences in the way the oncology community and even the guidelines and practices treat similar type of data in a different way, the reasons are not exactly clear, and there is not one particular reason. It's always a combination of many factors. For example, in case of pancreatic cancer, it could be, one of the reasons could be that yes1 is a Japanese drug, and it was a Japanese trial conducted in Asian population, and the Western population or the Western oncology community is not very open to those data. That can be understandable because previously there were some reports of differences depending on race or ethnicity. But what I propose is at least we should do the same trial in European population and check, because the data from the Japanese trial was very impressive. Overall survival gain of 21 months. But we see that this has not made into American guidelines or the European guidelines. But gemcitabine plus capecitabine, which is more toxic compared to S1, and the benefit of overall survival margin is not very large. It has made into all the guidelines and is recommended as a category 1 recommendation. So this is a discrepancy, this is a difference in treating similar data in a different way, and the reasons are what we call, there are many reasons, but one of those reasons could be, in this particular case, could be the not invented here syndrome. So those drugs that are not invented here are not trialed in this population. We are reluctant to those data, but I think the way forward is to conduct those trials in the local population and test if it gives similar results. So we should be more open to data coming from other parts of the world. Yeah, again, the factors can be many, but in this particular case, I think one important reason is the power of advocacy groups and public education. So breast cancer comes with a big public importance attached to it. Everyone gives more importance to breast cancer, but when you talk about lung cancer, the importance is given a bit low in the community for many reasons. One could be probably due to its association with smoking and the stigma associated with that, and other factor could be women cancers are for a good reason, they are given more priority. But the thing is, lung cancer should also be given more priority, and more people should be talking about it. We should educate people more about it. And I think that's interplay of various factors is the reason why lung cancer screening, despite having good data that low dose CT screening prevents mortality among high risk smokers, it is not being practiced widely, whereas mammographic screening, despite limited data, is being widely advocated. That's a very interesting question, and thank you. Yeah, what I propose is a center for sense in oncology. That is what I say, and it will act on various aspects, such as patient and physician education will be one important aspect of that, and working on co-development ideas and drug repurposing ideas. And as I said, there will be a lot of people with different levels of expertise, with various comments, different comments on those ideas. But I think a central network of healthcare professionals who are experienced and independent without any conflicts of interest, and they evaluate all the input coming from various sources, I think that will be the way forward. Well, I think I'm not proposing to replace pembrolizumab with a web-based application, but what I'm trying to say is we can have some very effective but cheaper interventions. Pembrolizumab is a good drug for lung cancer. There is no question about that. But we can also have other cheaper innovations that can be widely applied throughout the world that doesn't need any big instruments or any expensive technologies, and that can give you a similar magnitude of impressive survival benefit. But the problem is this type of strategies are not, they don't belong to one particular company, and any industry cannot make a lot of money out of it, so they are not being widely implemented. So we should be working on such technologies that can be widely implemented, and we can save many lives with such simple steps. So the question is not replacing one with the other, but of course integrating both and supporting more and more study and research on such type of simple innovations that I call cancer ground shot that can be applied everywhere. Yeah, that's a very important question. I put forward the example of statin in small cell lung cancer in order to compare that with, for example, ipilimumab in small cell lung cancer or bevacizumab in small cell lung cancer. All these three examples are examples of failed trials. Ipilimumab failed, bevacizumab failed, statin failed in small cell lung cancer. But the way we look at these three drugs are different. Ipilimumab failed, and the editorial mentions that although ipilimumab failed, maybe it will be effective, so we should keep doing other trials in various combinations. Bevacizumab failed, and the editorial mentions although it is non-significant, it is improvement. And statin failed, and the editorial mentions statin should not be trialed in any cancer. So the way we look at these cheaper drugs and the way we look at expensive drugs are different. We have similar data, but we are optimistic about the expensive drugs, but we are pessimistic about the cheaper drugs. We need to put them to the same level of evidence and the same level of judgment. Now about your question regarding why we keep doing big phase 3 trials for expensive drugs without having good phase 2 data to support that. I think that's a very important question, and that's one important concern that we need to address in oncology, and this is a big problem. One important reason is because until now, all the approvals are not based on value. Most of the approvals by the FDA and EMA, they don't take value into account. They don't take the margin of benefit into account. So if it is statistically significant, they just give approval, and you can price the drug as much as you want. If the drug improves only 2 weeks of survival, or the drug improves 2 months of survival, 20 months of survival, the price that you put on the drug does not depend on the benefit. So everyone is trying to get their drug approved. So even a small margin of benefit is okay. So they are trying to chase that small margin of benefit with a huge number of patients in an overpowered trial, and that will help them to get the drug approved. I think that's the reason why, despite not having good preclinical or phase 2 data, everyone wants to go to a phase 3 trial, so that if they get lucky with one blockbuster drug, then it will be equivalent to billions of dollars. Yeah, I very much think so, because the way the drugs are priced now is unsustainable. No country can afford these drugs at these prices for a long-term future. So there has to be a point where we should act. And another important thing is, if we keep on approving the drug that have very marginal benefit, then the industry will not have the desire or incentive to produce better drugs. So that is like giving compliments to a student who gets grade C in exam. So he will never work hard to get grade A. So we want grade A drugs. But currently we are giving compliments to a drug that has grade C. So we should definitely put value into the equation, and we should be asking more from the drugs that cost so much, because no country, no matter how rich the country is, can afford these expensive drugs at this level of benefit for a long-term future. Yeah, definitely. Immunotherapy are a good class of drugs. There is no doubt about that. But the problem with immunotherapies are they benefit only a small number of patients, but those patients can derive a long-term benefit. That is definitely there. But the number of patients they benefit is small. So what I'm trying to tell about this class of drugs is, in public, they have a huge hype. And public has a very big hope from immunotherapy class of drugs. So sometimes I see patients with ovarian cancer who come to me and say, "Doctor, I need nivolumab." So there is no data to support that finding, but public has been under the misimpression that if you get immunotherapy, then all your cancer will be cured. So first, we need to clear this misimpression. And second, we should definitely try new strategies to improve the response rate. We need to search for a better biomarker, because PD-L1 as such is not a good biomarker. So we need to look for better biomarkers to find patients who benefit and to find patients who don't benefit from the drug. But another important thing we need to keep in mind is the cost of these drugs, because these are very expensive drugs with severe financial toxicity and some actual lethal physical toxicity. So we need to always keep in balance about the harms of these drugs versus the benefit in a small number of patients. So I think the key step for us is to find a good biomarker so that we know who benefits and who don't. Yeah, thank you for asking. I actually like this topic because I have come from Nepal, which is a low-income country, and I have my experience of oncology in Japan, which is a high-income country. So I have seen both. I have both the experiences of working in a low-income country and a high-income country, and I have seen the difference in those countries firsthand, and the difference is quite big. Now, regarding Moonshot, it was a very ambitious project, and Moonshot focusing on immunotherapy and precision medicine, the attempt is to improve survival. Someone even dares to say cure cancer. But the data that we have about immunotherapy and precision medicine are sobering. We have some success, but it's not as dramatic as it was proposed to be. Now I want to compare that with cancer groundshot, which I call as the research and study and application of tools and methods that are applicable to everyone living in Earth, no matter where he is living. So these are the strategies that include, just for example, if we take the case of cervical cancer, now we can focus on how to improve access to bevacizumab for cervical cancer, or we can focus on providing HPV vaccination to everyone in cervical cancer. So if we provide HPV vaccination and cervical cancer screening, then no patient should die of cervical cancer, because this is a cancer that we can actually prevent, we can detect early, we can cure early. But the discussion will be about how to provide bevacizumab to advanced cervical cancer patients, which I think is illogical, because no patient should reach up to the stage of advanced cervical cancer. And this is an example of cancer groundshot project. If we can provide good vaccination coverage to everyone throughout the world, then there will be no patient who dies of cervical cancer. But now let's compare that with immunotherapy or precision medicine, and we are spending billions of dollars and we are getting only a couple of months of survival benefit. So this is a huge gap in our investment. So what I propose is, if we can, let's say, spend only 5 to 10% of what we are planning to spend on moonshots to groundshot projects, then probably we'll be saving more lives than Moonshot will ever be able to save. And that's an excellent question. And of course, I don't have a simple answer, but as there are so many players working on global health, like WHO, UNICEF, UICC, especially in this case, UICC, WHO, IARC, and other not-for-profit organizations that have global reach and that are working on global cancer control. I think all these organizations, including ASCO, ESMO, organizations that are involved in cancer care, should work together and channelize these funds to implement these strategies that are more valuable to saving lives than other strategies that are only useful for prolonging life. Of course, I'm not here to discredit prolonging life. It is important. Everyone wants to live longer. We need to have research, cutting-edge research on how to develop new therapies. But we should balance that with simple steps that can save so many lives but have been ignored.